We're happy to have Dr. Carotid here today on the new developments in carotid artery disease treatment.
Yeah. Well, thank you very much for having me here, and thank you for taking the time immediately after New Year's. So I'm actually going to talk about some of the new developments in carotid artery disease treatment. And essentially, this is my conflicts of interest. My boss is sitting in the audience, and he did not invite me to his New Year's party. So when we talk about extracranial carotid artery disease, I think it's important that there is several categories that we see in our practice. The one that we are most familiar is the symptomatic patients, where the carotid artery disease is actually associated with either ipsilateral ischemic stroke, transient ischemic attack, or even retinal ischemic events. But then there is quasi-symptomatic categories where patients may have no clinical symptoms, but if you look at the imaging, they actually do have evidence of ipsilateral ischemic events, either on an MRI or CT scan. And then there is the quasi-asymptomatic, where patients have no clinical symptoms, but actually if you put a transcranial Doppler probe on the middle cerebral artery on the same side, you can actually detect microembolic signals on that ultrasound. And then, of course, there is the quasi-asymptomatic category, where actually there is no clinical symptoms, but perfusion deficits are seen on the imaging, on cerebral blood flow imaging, and that can be augmented when you give them vasodilatory challenges. But nonetheless, all of them are really in the same category as asymptomatic. So for our practical purposes, there is the symptomatic patient and there are the asymptomatic patients with carotid artery disease. Now, how does carotid artery disease actually cause ischemic events? And there is three main mechanisms. One is actually the atherosclerotic plaque acts as a nidus for thrombus formation, and subsequent embolization into the distal branches actually leads to ischemic events. Second is a total carotid occlusion because of superimposed thrombus on the atherosclerotic plaque. And of course, the third one is hypoperfusion because there is significant narrowing of the lumen of the internal carotid artery, which reduces the cerebral blood flow to the ipsilateral hemisphere. Now, we always used to think of these three separate entities, but now that we realize that there is a considerable overlap, that the hemodynamic component and the embolic component tend to occur in the same individual with much greater frequency than them isolated or in isolation. Now, carotid artery disease is actually further classified based on severity. We talked about it being classified based on the presence or absence of clinical ischemic symptom, but it is also further classified based on the severity of stenosis. And essentially, these are the categories. You can actually have a plaque with no stenosis, just an irregularity. You can have mild stenosis, which is classified as 30 to 49%. Moderate is classified between 50 to 69%. Severe is actually 70 to 95%. And of course, you have the near occlusion category, which may or may not be associated with a string sign, but nonetheless, there is very limited flow going into the distal internal carotid artery. Now, how is the stenosis actually measured? And obviously, the principle is that you take the point of maximum stenosis or minimum lumen diameter and you measure the diameter. But more important thing is, what is your reference? How do you express it, or a fraction of what reference are you expressing the minimum lumen diameter? And for carotid stenosis, it is actually the distal internal carotid artery, which is used as the reference. But essentially, there's another part of the definition. It has to be the segment where the vessel walls become parallel to each other to avoid using the carotid bulb as your reference, which may exaggerate the degree of stenosis. Now, why is it important to categorize carotid stenosis both by severity and also by presence or absence of ischemic symptoms, or symptomatic or asymptomatic? Because it predicts the subsequent risk of actually having an ipsilateral stroke. So if you create a strata where you divide the patient based on severity and further classify them by asymptomatic and symptomatic, essentially you will notice two patterns here. One, patients who actually are symptomatic have already had an ischemic event are at much higher risk of having an ipsilateral stroke over the next 5 years. And second, patients who actually, if you look at the severity of stenosis, the greater the severity, the greater the risk of actually having an ischemic event, till you get to a point of near occlusion, where actually the risk starts to actually go down, which is paradoxical. So that is why it is important to classify patients both by symptomatic and asymptomatic status, and also by the severity of stenosis. So when you stratify patients with carotid stenosis, I think the most validated criteria are, as we talked about, the severity of stenosis and also the symptomatic versus asymptomatic status. For asymptomatic patients, people have also attempted further stratification using categories like looking for perfusion deficits on cerebral blood flow measurements, looking at vasodilatory challenges, looking for presence of microemboli detected by transcranial Doppler signal. But nonetheless, these are still unvalidated methodology for further stratification for patients with carotid artery disease. Now, we all know that carotid endarterectomy is a procedure that has been around there for 60 years, a very well-established procedure. And the procedure is that you make a linear incision on the side of the neck, you expose the carotid artery, you make an arteriotomy, and you basically remove the plaque away. And several clinical trials have shown which are the patients who can benefit from carotid endarterectomy or carotid revascularization. So essentially, these are patients who have 50 to 99% carotid stenosis, have an ipsilateral cerebral or retinal ischemic event, which are considered symptomatic, so they can actually benefit from carotid endarterectomy. And patients with asymptomatic stenosis can also benefit to a lesser magnitude, but nonetheless they can benefit. And what clinical trials have shown is patients who have a severity between 60 to 99% can benefit from carotid endarterectomy even in the absence of ischemic symptoms. So now you will ask the question, well, you already have carotid endarterectomy, why do you need another procedure? So why carotid stent placement? Now, the benefit of carotid revascularization is lost if your rate of perioperative stroke or death exceeds 6% in symptomatic patients. And in asymptomatic patients, the threshold of benefit is even more limited. If your rate of perioperative stroke and death exceeds more than 3%, the benefit of carotid revascularization in terms of stroke prevention is actually lost. Now, obviously, in clinical trials, these thresholds have been met. But what about the real world? Well, this was actually a study that was done, was a real eye-opener for many individuals. Over 100,000 patients getting carotid endarterectomy in the United States. They are Medicare patients. Now, if you look at the 30-day mortality, so in clinical trials, 0.6% 30-day mortality. For ACAS or asymptomatic patients, only 0.1%. But what is happening in patients who are being treated in the United States? So if you look at hospitals in non-trial patients, so these are hospitals that participated in the clinical trials, but they also are treating patients who are not part of clinical trials. So the patients that are not treated in clinical trials, the mortality is 1.4%, is much higher than what they were actually the same hospital. But when they were treating patients outside clinical trials, the mortality was almost like 3 or 4-fold greater. And actually the non-trial hospitals, so these are hospitals that didn't participate in these clinical trials, their rates are even higher. And the lesser the number of patients they treat every year, the greater the rate of complications or one more mortality. So if you look at these numbers, obviously the simple conclusion is that operator experience matters. The more the patients that one individual or one hospital treats, the better the outcomes. And that's not a surprise. This is true for any surgical procedure. However, trial operators, these are the same people who did this procedure in clinical trials. When they were treating patients outside clinical trials, the mortality was 3 times higher. Same operators, but could not reproduce the results outside clinical trials. Because certain patients are at high risk of stroke or death, regardless of who operates of them. And this is the concept of the high surgical risk patients. And then there was clearly a group of people who had a higher rate of complications with carotid endarterectomy, high surgical risk, independent of the operator experience. And then there was this push to actually have a less invasive procedure for the high surgical risk patients. So you can provide the benefit of carotid revascularization without an adverse risk-benefit ratio. And this is actually the procedure that was introduced. And here you can actually see the carotid stenosis. And you can see the high-grade carotid stenosis at the origin of the internal carotid artery as it originates from the common carotid artery. Now, essentially what this procedure requires is essentially initially you traverse the lesion with a microwire. You can see the microwire going across the lesion into the distal internal carotid artery. And this is actually a specialized microwire because it's not just a wire, it actually has a basket attached to it, the distal protection device. And the distal protection device is introduced past the stenosis in a collapsed manner. And what this distal protection device is like a basket. It's like an inverted basket. And the basket is placed in the distal internal carotid artery. So when you're actually performing the procedure, any debris that may be released doesn't really go to the intracranial blood vessels, but actually is trapped by the basket. And here you will actually see the basket, as the sheet is withdrawn, you can see the basket actually is released into the distal internal carotid artery. What you don't see, the radiolucent part of the basket itself, that has pores that are small enough to prevent any debris, atherosclerotic debris, from going to the brain, but yet large enough to allow blood flow to continue on, so the blood flow is not interrupted. Now the next part is actually an angioplasty. Here you can see an angioplasty balloon that is brought across the lesion. And here you can see the inflation of the balloon using a mixture of contrast and saline. And usually we perform the first angioplasty, that is a submaximal angioplasty. And the goal is really to create or increase the diameter of the internal carotid artery to the extent that the stent device can go through without any obstruction. The next part is actually the stent, and these are self-expanding stents. And what that means is that actually withdraw the sheet, the outer sheet of the stent starts to deploy by virtue of biomechanical properties. And here you can see the stent being deployed across the blood vessel wall, clearly abutted to the surrounding vessel. And then we perform another angioplasty within the stent, and this is usually performed with a much larger balloon. So this is actually maximal angioplasty. And the goal of this angioplasty is to remove any residual stenosis that may be left despite the placement of the stent. And here you can see immediately after the stent placement, there is complete resolution of the stenosis with no residual stenosis that can be visualized. And the stent appears to be in adequate position in relationship to the surrounding vessel. Now, however, if you remember, we did put this basket up there, which is still there, and may be filled with particles that maybe have been released during the procedure itself. So now we have to remove that basket. So we bring another sheet here that actually moves over the basket and collapses the basket in a manner that it traps any particle that are within the basket and prevents it from being released into the circulation. And once that basket actually has been compressed or collapsed, essentially what you will see is the whole system is actually removed from the intravascular compartment. Here you can see this collapsed basket being removed from the intravascular compartment. So now we have a procedure. Is there any evidence that this procedure actually does provide benefit to patients with carotid stenosis? When obviously the first population to study this procedure was the high surgical risk patients, patients in whom carotid endarterectomy led to a higher risk of stroke and death within the 1 month post-procedure. So the first trial that evaluated was stenting and angioplasty with protection in patients at high risk for endarterectomy, or the Sapphire trial. Now this was actually a clinical trial that included patients who had symptomatic disease, 50% or greater, or asymptomatic disease, 80% or greater. So both categories of patients could be included in this trial. But they were high surgical risk, which meant that they had one or more of these categories that make a patient high surgical risk for carotid endarterectomy. So either they had significant coronary artery disease, severe pulmonary artery disease, they had a contralateral carotid occlusion, contralateral laryngeal nerve palsy, previous neck surgery or radiation therapy to the neck, or actually had previous endarterectomy and the stenosis had just come back. So essentially, because of a high content of fibrous tissue in the surgical field, surgery the second time around is more complicated. And again, patients who have contralateral carotid occlusion, because if you remember, when carotid endarterectomy is performed, there is a period of time where you have to interrupt blood flow in the ipsilateral internal carotid artery. And if you don't really have a contralateral carotid artery that's patent and provide collateral circulation to the ipsilateral hemisphere, you actually have a higher risk of having ischemic events during procedure. And of course, significant cardiac disease and pulmonary artery disease are high risk for general anesthesia, and carotid angioplasty and stent placement can be performed in awake conditions. So the trial actually looked at the following endpoints. So within 30 days, any stroke, myocardial infarction, so any elevation of cardiac enzymes after the procedure, or death. And then at 12 months, any ipsilateral stroke. And again, all of these events were adjudicated by an independent committee, not actually by the physicians who were performing the procedure. So actually, if you look at this, 307 patients were randomized, high surgical patient randomized, 156 to stent, 158 to endarterectomy. Now, if you look at the 1 month stroke, myocardial infarction, and death, plus 12-month risk of ipsilateral stroke, the numbers are 11.9% with stent placement, 19.9% with endarterectomy. A significant benefit of stent placement over endarterectomy in this particular patient population. So I think this trial clearly established that carotid stent placement may be a superior procedure as compared to carotid endarterectomy in the high surgical risk patients. Now there's actually another interesting observation. Like there may be patients who met the criteria but did not want to get randomized, or their physicians did not want the patient to get randomized. So they could actually get the stent placement, or they could get the endarterectomy, and they will be included in the registry. And interestingly, 409 patients actually got included in the stent registry, only 7 patients in the endarterectomy registry. That actually shows a very interesting pattern of physician and patient preference when it comes down to choosing a procedure. So in CMS in 2004 concluded that carotid angioplasty and stent placement with embolic procedure is reasonable and necessary for patients who are at high surgical risk for endarterectomy and have a symptomatic carotid stenosis that's 70% or greater. So the procedure itself got eligible for reimbursement if it met the following criteria. 1, they were high surgical risk, and secondly, they had symptomatic 70% or greater carotid stenosis. But when you see results like this, people start asking the next question, well, should carotid angioplasty and stent placement be the first line treatment for conventional risk patients, not the high surgical risk patient, but conventional risk patients? And then this was the second trial, the carotid revascularization, endarterectomy versus stent trial. And this trial recruited patients, again, both symptomatic and asymptomatic. Initially, the trial actually wanted to recruit only symptomatic patients. However, because of recruitment consideration, the trial actually started to recruit asymptomatic patients as well. And Patients could be included by different categories. You could actually have a angiogram confirmed stenosis. You could have a stenosis that's confirmed by ultrasound, or you could have a stenosis by CT or MR angiogram, because at this point, both of these modalities had become more widespread and more readily available. And the category was somewhat different. With the angiogram 50% or greater, with a non-invasive testing 70% or greater, because there was this concern that non-invasive testing may overestimate the severity of stenosis. And for asymptomatic, 60% or greater went by angiogram. If you're using ultrasound or CT angiogram, a higher severity was required to be included in the trial because of the same consideration that non-invasive testing may sometimes overestimate the severity or the actual severity of carotid stenosis. And these were conventional risk patients, not high surgical risk patients. And the primary endpoints, stroke, myocardial infarction, and death. Now, there is a difference in the definition of myocardial infarction, which is different from Sapphire trial. Because the Sapphire trial required you had to get cardiac enzymes measured within 24 hours after the procedure, whether you had symptoms or not, and therefore people felt that that was not a valid endpoint. So in the Crest trial, you had to have EKG evidence, not just cardiac enzyme elevation, or clinical symptoms of myocardial infarction before it was considered a myocardial infarction event. And then over the next 4 years, any evidence of ipsilateral stroke, and again, all of these events were independently adjudicated. Now, the other thing that this trial did was it put a lot of emphasis on expertise of the operator. So it really didn't want anybody to be doing procedures. So for carotid stent placement, 427 people applied to be operators in the trial. In the end, only 224 people or interventionists were selected. So very rigid criteria about operator expertise and knowledge of the technique. So this was actually the trial. 2,500 patients were randomized. So it's really one of the largest trials that have ever been done for carotid revascularization. 1,252 randomized to stent placement, 1,240 to carotid endarterectomy. The primary endpoint is a cumulative endpoint, 1 month rate of stroke, myocardial infarction, and death, and the 4-year rate of ipsilateral stroke. So if you look at the rate, it's dead same, 7% and 7%. Conclusion, carotid endarterectomy and carotid stent placement provided exactly the same results when it came down to endpoints of the trial in this particular group of patients that are considered conventional surgical risk. But some things to know that the combined endpoint was exactly the same, but the kind of events that made the combined endpoint was somewhat different. And in clinical trials, it seems that the cranial nerve injury is much higher with carotid endarterectomy, which is what you would expect. They're actually operating in a surgical field that actually does have the laryngeal nerves right in that field. The myocardial infarction, again higher, much higher with carotid endarterectomy, because general anesthesia is used, and a lot of these patients who have carotid artery disease also have coronary artery disease. In fact, carotid artery disease and coronary artery disease go hand in hand. But when it came down to stroke, it seemed that the stroke rate was somewhat lower with carotid endarterectomy as compared to carotid stent placement. So the overall endpoint rate appears to be the same, but the individual endpoints may be somewhat different between the procedure. So myocardial infarction rates and cranial nerve injury rates are lower with carotid angioplasty and stent placement. The stroke rates may be higher with carotid stent placement. Now, another thing that came out was age. There was an increasing data or new data coming in suggesting that the rate of complications with carotid angioplasty and stent placement actually increase as patients, the older patients, are being treated. And in fact, a sharp dichotomy can be seen. In 2 trials, if you look at patients under 75 and patients above 75, and you look at the 1 month rate of stroke and death, the rate actually changes very dramatically between younger age and older age patients that are getting carotid angioplasty and stent placement. So this is actually an interesting observation that invoked a lot of debate because it was paradoxical. Carotid angioplasty and stent placements were introduced in the first place for elderly patients who have multiple medical comorbidities. But why are we seeing a paradoxically higher rate of events, negative events, adverse events after carotid angioplasty and stent placement in the elderly population? But perhaps because carotid angioplasty and stent placement may be more risky because these people have concurrent aortic artery disease, they have tortuous arteries, they have a lot of calcified plaque. So now the question becomes is that should carotid endarterectomy be preferred in the elderly population? But this is actually interesting that if you look at what's happening in the United States, this is an analysis that we did of 500,000 people who had carotid revascularization. If you look at patients under 70 and over 70, most patients in the United States that get treated are over the age of 70 years. So by default, carotid revascularization is a procedure of the elderly patients. Now, if you look at the age-related increase in post-operative stroke, cardiac complications and mortality, and look at carotid endarterectomy be performed in the United States, and look at carotid stent placement. And what you see is, yes, the risk is actually higher in the elderly population, but it's higher with both procedures. The risk is 30% greater odds if you get carotid endarterectomy, and a 30% greater odds if you get carotid stent placement. So the only important point here is, it doesn't matter what procedure elderly patient get, there is actually a higher risk of complication in elderly individuals. So in the United States, most procedures are really performed in the elderly age group, and the high rates of post-operative complications are observed among these patients, but it is independent of the procedure choice. So now it comes down to what is a management algorithm. We have all this data from clinical trials. How do we use it to see what the next patient that we will see in our practice, and how do we select a procedure for that patient? So this is actually a scheme. As always, symptomatic patients and asymptomatic patients have to be considered differently. As we learned earlier in the discussion, that the risk of ischemic events is different. So we have to consider them in a separate bag or separate categories. And further dividing them into high surgical risk and conventional surgical risk. Now, if they're symptomatic, the risk of actually having an ipsilateral ischemic stroke is high. So even the high surgical risk patients can benefit from carotid revascularization. So carotid stent placement appears to be the preferable procedure in symptomatic high surgical risk patients. Now, conventional surgical risk patients, I think that there is a dichotomy by age. And there is some debate that whether the elderly patients should preferentially get endarterectomy over stent placement, and the younger patients should get stent placement preferentially over endarterectomy. But I showed you the data. It doesn't seem that it is the procedure type that determines complications in elderly patients. Somehow elderly patients are just higher risk for post-operative complications than death, regardless of the procedure. So both procedures are viable options. Now, asymptomatic patients, high surgical risk. If they're high surgical risk and they're elderly patients, I think we have to come to this terms with this concept that there are a certain group of patients that actually have carotid artery disease where the risk of treatment is higher than the natural, or worse than the natural history of the disease itself. So if you're asymptomatic, you're high surgical risk, you're 75 years or greater, the risk of treatment probably is higher than the benefit of the treatment. And those patients will perhaps just be best managed with medical treatment alone. Now, if you're in the younger age category, carotid stent placement may be an option, but in carefully selected patients. For conventional risk patients, again, there is some question about the age dichotomy, but again, both carotid angioplasty and stent placement and carotid endarterectomy appear to be viable options in this particular category of patients. So I think when you select patients and select the procedure, you have to divide them by symptomatic and asymptomatic, and further classify them by high surgical risk and conventional surgical risk. And I think it's also important to recognize that there is a group of patients where medical treatment alone is preferable to any carotid revascularization procedure. Now, obviously, the scheme looks very simple, but it actually is complicated. It is complicated by patient preference. Some patients don't want to have surgery. They just want to have a minimally invasive procedure, and regardless of the scientific data that you present to them, they actually have a preference for a less invasive procedure. And at times, that has to be put into consideration. We talk about high surgical risk, but there's also a high stent risk group of patients. There are patients who may have severe peripheral vascular disease, so actually getting vascular access may be a problem. They may have severe calcified and tortuous lesions. They may have severe aortic arch disease, and they may actually just be high stent risk, in which case carotid endarterectomy should be preferred. But in the end, I think that what really determines what procedure is selected for your patient really varies between institutions. And local institutional expertise appears to be the most important determinant of procedure choice and what is actually occurring in the United States today. Now, one last thing I want to talk about is timing of intervention. We all know about time window. We always talk about time window for treatment of acute ischemic stroke. Everything about time window. If you treat a patient within the appropriate time window, you can get a benefit. If you treat it beyond the time window, you will get no benefit. But this is actually true for carotid endarterectomy as well. And people don't recognize it. That it is actually a true quality parameter. How long do you wait before you actually get a patient carotid revascularization? So obviously the purpose of revascularization is to prevent a second stroke from happening. So if you look at the risk of second stroke or recurrent stroke after somebody who presents with a first ischemic stroke, if you look at patients who come in with large vessel atherosclerosis, which really includes mainly carotid stenosis, if you look at the risk of recurrent stroke, it is really front-loaded. And most of the recurrent strokes occur within 7 days, within 1 month, and definitely by 3 months. So there is almost a time window. If you really want to reduce the risk of actually having a second stroke, you must intervene early to put the right preventive strategy in place. Otherwise, it may just be too late. Your effort to prevent a second stroke may just be too late because the second has already occurred by the time you actually perform a carotid revascularization procedure. So I think it's important to recognize that there is a time window, and the risk of recurrence or recurrent ischemic stroke with carotid stenosis or symptomatic carotid stenosis is very, very early on. It's all front-loaded. So there is actually time window for intervening to provide the maximum benefit. And actually, if you look at the timing of carotid endarterectomy in patients with symptomatic carotid stenosis, it appears that if carotid endarterectomy is delayed, so if you take longer time from the last symptomatic event to actually being included in the trial, the effectiveness of the surgery keeps going down. And actually the maximum benefit is seen in patients who actually were treated within 2 weeks of actually having the ischemic symptom that actually brought and identified the carotid stenosis. So I think it's also important to recognize that there may be a time window for intervening in patients with carotid stenosis, and we have to expand this concept of time window beyond just acute ischemic stroke. So I think I'm actually going to conclude here. I wanted to make sure there is some time left for a discussion. And I think the conclusions here are that carotid stent placement has the potential to reduce the rate of ischemic stroke associated with extracranial carotid artery stenosis. But appropriate adoption and implementation strategies for carotid stent placement will be the key for the success of this particular procedure. Well, thank you very much. I think Dr. Walry would actually come and introduce the topic.
No, actually, open it up to questions. I have a couple of questions for you. Maybe, we can kind of address some of this. Was I of the misconception that for asymptomatic carotid disease, that women tend to do better with best medical management than men? I mean, do you separate that out? We didn't talk about that today at all. I don't know if that's separated.
I think that's an excellent question. That if you look at the benefit of carotid endarterectomy, it seems to be greater benefit in men as compared to women. And part of it is that it's thought that endarterectomy is more difficult in women as compared to men. And one concept is that the neck is actually shorter and thinner, so it's more difficult to expose the anterior carotid artery. Whether that's actually true, unclear. Whether it's reproducible across the trials, not consistently. So should there be a different paradigm for women as compared to men? And when carotid stent placement came in place, there was a push towards that maybe stent placement, because there is no surgical procedure required, maybe it's a preferable option for women. But so far, the data has not shown any consistent benefit or extra benefit in women as compared to men with carotid stent placement. So whether gender should be used in some selection criteria, I think that is still debatable. I would say it's still debatable.
Okay. We often get imaging studies. That maybe come up with results that may or may not have been expected. For instance, in screening, we come up with this carotid ultrasound of 50 to 69% stenosis. How do we manage those patients? I mean, when do we follow up? Do we put them on single, dual antiplatelet therapy? How do we manage most individuals?
So this is a very interesting question. And I think that what Dr. Waller is alluding to is that the natural history of asymptomatic carotid stenosis seems to be getting better as the years have gone by, because now we have more antiplatelet agents at our disposal. We have a greater clarity about use of statins, and also a greater level of comfort in being more aggressive with antihypertensive treatment. And it appears that if we use a combination of all three, the risk of actually having an ischemic event with asymptomatic carotid stenosis is probably even lower than was actually seen in the clinical trials. So again, it just comes down to that there is clearly a group of patients with carotid stenosis who should best be managed with medical treatment. So essentially, if the patient has moderate carotid stenosis, is asymptomatic, best medical treatment is probably the answer. Now the question is, what is best medical treatment? Because that itself is a whole spectrum of what it can be. And in general, N1 antiplatelet, not to one antiplatelet, statin to keep or maintain the LDL cholesterol to a value of less than 70 milligram per deciliter, and maintaining systolic blood pressure to a value, or blood pressure to a value of less than 140 by 90 millimeter of mercury is considered best medical management. Now, some of you will question that maybe this LDL cholesterol threshold is lower than what we are used to, because for for a few years, all our goal was to keep the LDL cholesterol less than 100 milligram per deciliter. But actually, Sampras, which was actually intracranial angioplasty and stent trial, showed that you can really have dramatic results if your LDL cholesterol target is less than 70 milligram per deciliter. And actually, in the ongoing Crest 2 trial that is looking at asymptomatic patients and randomizing them to stent placement, endarterectomy, or best medical management, the goal of LDL cholesterol is less than 70 milligram per deciliter.
So how often do you follow them on ultrasound?
And that is actually a debated question. One, whether progression itself is a marker of an impending ischemic event coming on. And I think that there is not clarity on that particular question. But in general, I think an yearly ultrasound is probably the best way, unless you have real reasons to believe that something will be changing within a 6-month period. I believe that 6 months is just too short an interval to show any change in the severity of stenosis.
Okay. So on that note, then, do you follow those patients with a CT angiogram or a conventional angiogram? And then do you look at MRIs to see maybe if there's silent infarcts? And go ahead.
And I think it's a very important question that can we further stratify asymptomatic patients and kind of try to identify asymptomatic patients that are at higher risk for ischemic events and those who are at lower risk, and actually only treat the asymptomatic patients that are at higher risk for ipsilateral ischemic stroke. And many things have been tried, as Dr. already mentioned, that looking at asymptomatic infarction on the same side by MRI or CT scan, actually looking at regional cerebral blood flow, giving vasodilators to see the perfusion deficits. Are they actually real? Are they actually masked? And when you give a vasodilator stimulus, you can actually unmask the perfusion deficits. But none of them actually has truly been shown to be an adequate predictor of ipsilateral ischemic stroke. So I think that in some ways we are left with what our individual preferences are, and we have to accept that we just don't have high quality data to guide how do we manage these patients. And yet, Dr. Wall is essentially right. The most common carotid stenosis patient that you will see in your practice is going to be the asymptomatic carotid stenosis patient.
If you see an incidental stroke on a particular cerebral hemisphere, patient wasn't aware of it, is that symptomatic or asymptomatic?
It actually is asymptomatic with the classic definition that we have.
Okay.
Now, there is another part that is actually still not validated, is what about cognitive deficits? Fine, they don't really have a clinically ischemic stroke, but what about actually having these silent ischemic events, and that is actually taking a toll on their cognitive function? And whether treating those patients would actually prevent a cognitive decline, because remember, cognitive decline is 5 times more common, if not more, than an ischemic stroke in the United States population. So maybe preventing cognitive decline can be a valid endpoint, but it has to be validated in future clinical trials.
One last question, and then I'll kind of stop bugging you here. So since a lot of these trials came out in the early 2000s, late 90s, there's been a lot of different or better definitions of what constitutes best medical management. We talked about it a little bit as well. There's also been a lot on the treatment side of it, whereas there's been better devices, better technique, more defined technique, and I think better training, better experience down the road. What do you think the future holds for our stratification of risk as far as best medical management versus interventional type maneuvers? What are we leaning towards? And do you think the trial should be essentially re-performed? Because now what we're looking at is a lot of studies look at Cochrane databases and whatnot. But should we redo some large trials, and do you think they'd come out differently?
I think that the Crest 2 is exactly following the paradigm that you recommend. They're actually really redoing the asymptomatic carotid stenosis trials, because they do have a best medical treatment arm and they have an interventional arm. So it is actually a ACAS trial basically being redone all over again. And the thought is that the best medical management has actually advanced to this level, that perhaps in many asymptomatic patients, best medical management can achieve the same results as carotid revascularization, something that was not possible when the ACAS trial was actually performed, which was actually published in 1995.